Okay, should we make a start? Okay, brilliant. Okay, well, I am, it seems, the chair, which is very exciting. I've never done a chair at these things before. So hello, everyone. My name's Nick. I'm Nick Dixon. I am a research associate. I work here at the School of Health and Wellbeing. Thank you so much for coming along, the chosen few, because I know there's a lot of things happening in this building today. We've got people moving from the fourth floor to the third floor. We've also been, a lot of us have been instructed to work from home. So this is great. We're all here and we're all here. Welcome, Vaughn. So it's a massive honour to have you here today. Professor Vaughn John, and I'm going to probably mispronounce things, so keep your eye. And so you're from the University of KwaZulu-Natal in South Africa. Thank you. Yeah, I'm getting into my groove now. Okay, so I'm just going to give a little bit of background of who Vaughn is, not John, Vaughn, and how I know you, and what you're going to talk about today. So I'll just keep myself right here. So you hold the South African Research Chair in Peace and Justice Education, a prestigious role that reflects your lifetime commitment to using education for a tool for healing and social transformation. Vaughn's work emerged in response to political violence in KwaZulu-Natal, and over the past 3 decades, he has developed more than 20 peace-building interventions across community, school, and post-school settings. Now, in recognition of your inspiring work, I saw this happen. He was at the International Adult and Continuing Education Hall of Fame. And that's a global honour that celebrates outstanding leaders in adult learning. His induction acknowledged his pioneering contributions to critical peace education, transformative learning, and participatory pedagogy. And these are all approaches that challenge traditional top-down models of teaching and help foster dialogue, reflection, and collective action. These are really important values, and they're deeply rooted here within the School of Health and Wellbeing, because we strive to improve health, not only through clinical excellence, but also through inclusive, community-based, and socially just practices. Now, I met Vaughn when I was at a conference. I'm involved with this charity called the SHW, which is the Standing Committee on University Teaching and Research in the Education of Adults, which I'm currently the joint co-chair. And me and Vaughn had a bit of a connection because I went to his things and he came to my things, and we were like, oh, I like what you do. Yeah. And so you've come along to a number of them over the years, and you came to one of my workshops, and we spoke about our mutual interest in participatory approaches, which often center on lived experience, creativity, and social justice. In fact, we're planning on doing some webinars together. So we're going to do webinars for your students. We're also going to do a zine making session, and that's with trainee teachers in South Africa with lived experience of trauma. And it's very much a collaboration based on our shared values and beliefs for education as a tool for healing and change. But he's not here to tell you about that today. No, that's just my thing. So today, Vaughn's going to talk about the STAR intervention, and that's about strengthening teamwork and respect, a participating learning and action approach designed to equip rural health workers as change agents for respectful maternal and newborn care. Now, my understanding is this is developed in partnership with the South African Medical Research Council and the London School of Hygiene and Tropical Medicine. Yeah. Okay. And STAR embeds participatory learning into routine service delivery to help foster ownership, accountability, and sustainable change. Now, Vaughn's going to tell you all about that today. That's not what I'm here for. But I have seen Vaughn speak before, and it's really powerful to witness how this program tackles really difficult situations in medical practice. What's especially compelling for me is how participatory learning, which involves people actively engaging together for dialogue, reflection, and problem solving, is central to the success of the intervention and critically embedded in the research. That's all I have to say. Please join me in welcoming Professor Vaughn John.
Thank you, Nick, and thank you, all of you, for being here today. I appreciated the little bit of background because what Nick spoke about in terms of peace education is really what I spend most of my time doing. And what I'm talking about today is a project that's, I've only become involved in health projects over the last sort of 8 years. So when I came to the university, the province that I live in and the province that this study took place in, KwaZulu-Natal, was in a civil war in the 80s and 90s. It was just prior to the to democracy in South Africa. And it was an attempt, a deliberate attempt by the apartheid government in the final years of apartheid to kind of weaken the democratic forces. So they created a political violence that actually, 20,000 people died in that violence. And I was training to be a psychologist and entered into a project and I spent the first 6 years of my work at the university monitoring that political violence and assisting communities that were displaced. And when that violence came to an end, we started to get involved in peace education. So we launched some of the first peace education work at the university, and I've continued with that for over 3 decades. So that's really what I do for most days in the week is in a chair of justice education that was set up last year. And we currently actually building and developing a new project called the Legacies of Violence program, because what we have realized is 35 years later since that violence, we're still dealing with the consequences of that violence. There's intergenerational transmission of trauma and violence, and we kind of building interventions, participatory interventions like the one that I'm going to be talking about today, but in the context of assisting communities that were affected by violence. So I often talk about that at conferences, and I meet Nick. I've met him now 4 years at a conference, the University Adult Lifelong Learning Association of Lifelong Learning, and Scrutria. And we saw the connection because Nick often works with marginalized communities using arts-based approaches. And I thought, well, that could be really interesting to include in the peace education work. But what I'm talking about today in the context of health, and this is the first time I think that I'm actually speaking to scholars in a school of health and wellness. I've really been in education all my life. But over the last few years, I've been involved in 2 large health projects because they needed someone from education, because they were educational interventions. So we have a large project, a Norwegian-funded project that's growing, developing nutrition epidemiology capacity in the Democratic Republic of Congo and Tanzania. And that project brought me to a big conference in Paris for all of last week. And it gave me the opportunity to add this trip to it. And through that work and working with sort of people in health, I was asked to get involved in this project, which was really responding to disrespectful care in hospital settings, in maternity wards. And so the PI for this project is from the South African Medical and Research Council. It's funded by the UK Research Council, and it involves 2 colleagues from the London School of Health and Hygiene and Tropical Medicine. And then from the University of KwaZulu-Natal, it's myself, an organizational psychologist, and a Center for Rural Health. And it's so good to see a former colleague from that university, Professor Dennis Francis. So my involvement in it comes into it because these colleagues who understand maternal health recognized that there was a need for an intervention study, and it needed an adult educator to develop it. So the part of this 3-year project that I'm going to focus on today is really the part that I led, which is the development of a participatory learning and action intervention to help strengthen teamwork and respectful care in maternity wards in 9 rural hospitals. And I will, though, share some of the aspects that I wasn't involved in, which is because this was an intervention that had baseline research and endline research. First time that I've been involved in such a study. In peace education, we don't get the funding to do these large studies. So it was really interesting for me to learn new methodologies and almost working in quite a different paradigm, because I think a lot of my work is very much located within the critical paradigm. But because it was participatory learning and action, which we're familiar with in peace education, in community development work, I thought, well, it'll be interesting to see how this works in a very different setup, which is a hierarchical kind of hospital structure in rural communities. So that's what I'm going to talk about. So I'll just share a little bit about the baseline and endline at the beginning and the end, but I'm going to focus really on the intervention which we developed and ran over a year in these hospitals. So I will start by just saying that respectful maternity care is a human right. And 3 decades of research on poor quality maternity care in South Africa and increased global attention has kind of raised the importance of respectful care and led to revisions of policy and guidelines. South Africa has made some strides at the policy and guideline level. And so, for instance, the 2024 National Guidelines for Maternal and Perinatal Care for the first time has a chapter on respectful maternity care. But while there's change at the policy and guideline level, there hasn't really been much work or evidence about how to actually improve respectful care. So we have occasionally sort of once-off, top-down didactic teaching courses that would be offered. But those kinds of interventions don't really foster self-reflection, teamwork, or any sustainable learning cultures within the health systems. So they're very much one-off. And so that context, sorry, that's the, this is a slide. I'm working with 2 computers, so apologies. What we've had is these kinds of once-off interventions, and we were really looking for something that we could create that may become more sustainable within clinical practice in the hospitals. So this led us to a research question on considering how participatory learning and action groups within amongst health workers could enable local problem solving and strengthen respectful care for newborns in rural districts. And we chose the rural districts because those are the least resourced and often have the most challenges from in terms of staffing, staff shortages, stock outages, maternal morbidity rates as well. So the setting is the province of KwaZulu-Natal, where my university is located. And we chose 2 rural districts, Umzinyathi and Zululand. And we chose these specifically because they were amongst the largest districts carrying quite a high burden around maternal care, but also with high maternal morbidity rates. And we selected all 9 district hospitals in those 2 districts. So this is the kind of biggest study. It was a mixed methods implementation research study with a before and after evaluation design and continuous process evaluation with some qualitative case studies. There's also a component which is just taking place at this point because we've now completed the intervention where we have a health economist that is doing the kind of costing of the entire intervention to give us a sense of what it may mean for the country if they chose to scale up this intervention. I'm only going to share 2 sets of results from the baseline just because it helped inform the intervention that we developed. I wasn't really involved in the baseline or the inline data collection, nor with the process evaluation. And I think most of you understand the need for that separation. And so I worked with a small team, which were just the kind of intervention. But we were given some of this data because it was obviously important for us to know this in developing the intervention. And so one of the tools that was used in baseline and endline was the Dimensions of Learning Organization questionnaire called the DLOC, and that looks at learning cultures in organizations. And what this showed us was that different cadres of health workers experienced learning, quite differently. So, for instance, doctors and managers felt like they were involved in learning opportunities and benefiting it, but health workers at the level of kind of professional nurse and enrolled nurses particularly had experiences where they felt that they were frequently excluded from learning opportunities and felt less empowered. So we wanted to address that kind of setup. The other measure that was done at both baseline and endline is a tool called the Person-Centered Maternity Care Survey. Is that a familiar tool for an audience like this? Not? Okay. Well, it was new to me as well. I thought it may be better known here. But it asked questions like, whether the mothers were given an opportunity to have someone with them, a birth companion during labor, whether they felt that they were treated respectfully, and you can see from this only 6% of mothers were allowed a birth companion. 1 in 5 experienced some level of verbal abuse. Just over half felt that their health information wouldn't be kept confidential. But overall, there was a fairly high kind of indication of overall respect that mothers indicated. So we took that information and then went into the process of developing an intervention. This is the broader team, including colleagues from the London School of Hygiene and Tropical Medicine and the kind of more clinical expertise. So it involved people from adult education, a midwife, an organizational psychologist, health system researchers, epidemiologists. So quite a diverse range of different disciplines and skills involved. I worked specifically with colleagues from adult education, and we had someone with some clinical experience, and we had an organizational psychologist on the team. And some of those pictures indicate the kind of work that we did over a year in developing the intervention. So the approach we were using is called participatory learning and action, which is a approach used a lot in community settings. It was inspired by the work of Paulo Freire in Brazil, and largely because it's a bottom-up learning process that respects and activates local knowledge and agency. And it's one that, if done well, and if it gains some traction, could be a process that could continue. So it could be something that could be embedded in health systems and in learning systems. My experience of PLA was really in community settings, where often community groups would work to understand their context, to read what's happening, to plan some action, take some action, reflect on that, and it works in cycles like that. So it was really interesting to try this out in a health setting. It had been done in other places. The literature that we read showed some implementation of PLA in hospital settings in the Netherlands and in other parts of Africa. It had not been done, to our knowledge, in South Africa. And I must say, I particularly thought that there may be some tensions with trying a kind of community-based process in a very hierarchical kind of power-laden structure like a hospital. But I'll share some of what happened and our reflections on that. So a PLA works in a typical kind of cycle of deciding, planning, taking some action and reflecting on that action. We did some visits in the hospitals that we were wanting to work in, and we tried to understand what kinds of learning processes take place in the normal course of a ward. And we found that they did have some audits, particularly if there was a maternal death or some other crisis. They would have an audit, and the staff would spend some time kind of analyzing that. We also kind of became aware through those visits that there were times when, if a new policy was introduced or some other procedure was introduced, that the staff would spend some morning, particularly when shifts overlap, to kind of have a briefing. So we decided that that was going to be the space we'd use, rather than trying to require very busy wards to create another learning space. And we learned from observing those sessions that what was happening was that they were following pretty much the 4 steps of a learning cycle, and we added confirm, because we thought what was happening was, if they learned that something wasn't working or that something was working, it didn't become embedded in practice. It kind of became a learning, and then they kind of moved on, and then they'd find similar kinds of things. So we changed that in our approach by adding that 5th part, and it kind of worked out quite neatly because of the star as well, to have a 5 points there. So this sets out the long process that we spent over a year in the implementation development. And we started off, as I said, by some observations in hospitals. We reviewed a lot of literature around both maternal care and PLA. We looked at policy, and we also looked at other health manuals. You know, what other ways have been attempted to develop and improve quality care in hospitals. We produced a draft of the toolkit, which we then took to a reference group, which was one of the hospitals in Dundee. And that was really helpful because we were able to try out some of the activities, see if the language was accessible, see if the timeframes that we were planning for activities were reasonable, and those sorts of things. So we learned quite a bit about that, and then revised the toolkit. And then we sent the revised toolkit to 2 critical readers, and we tried to find people who had both clinical experience and some education experience as well, so they could tell us what they thought. We took that feedback into a further stage of revision of the toolkit, and we then went into a piloting at 2 community centers in these district community health centers, and then got further feedback, which we put into the final revisions and layout. And then we developed a toolbox that went. I'll show you a picture of it. So that picture on the side there is really the reference group meeting that we ran in Dundee in one of the early testing phases. So the toolkit we developed had a number of things in it. So this was the infographic poster that we created, which would explain the process, but also allow the hospitals to put it up on the ward so that they can tell staff and also patients as well about what was going on. We spent a lot of time developing the activities so that they'd be participatory activities. So there were 14 of them, plus some videos that we found, and we put those on a memory stick and put them in the kit as well. And we made references to the maternal and newborn guidelines because that was very important. We didn't want this intervention to be something that sat outside of what government and the provincial health department required of people. And we had a toolbox which had things like stationery and forms, and we provided some data and a router for the 12 months because in these rural hospitals, communication was often a problem, and we wanted to be able to, for them to be able to contact us so that we could provide support. We also developed T-shirts with the star logo and mugs, just as a way of trying to create identity within the hospitals of the STAR project and the team. And you'll see that in some of the pictures. So that's the toolbox on the right, which had all the stationery and forms and files and things. And that's the cover of the manual, which had the 14 activities and guidelines on learning and how to set up sessions and so forth. So this is a sense of the types of activities that we created. So we had activities that allowed them to plot their schedules so that they could find common times for learning. A transect walk was a very helpful activity which got staff to walk through the facilities and see it through the eyes of patients. It was very, very, directed a lot of the projects, and I'll talk a bit more about that. But reflection exercises, role plays, we had case studies. So we took some of the data from the baseline because there were focus groups with mothers, and some of the experiences that showed disrespect, we kind of anonymized it to remove the names of the hospitals and staff and created case studies so that it became an activity for staff without it being threatening. And then you can see some of the kinds of activities here, which is the speech bubble activity, which almost gets health workers to try to think about what patients may be thinking or feeling when they're sitting for many hours in a queue in a hospital setting and so forth. So that's activity 6. The PLA works in community settings where you often have to identify, or the group identifies, a kind of facilitator or animator of the process. We call this a champion, and we asked the group, so we gave them guidelines. We visited each of the 9 hospitals to introduce the project, gave them some selection criteria for constituting a team and selecting a champion, and we asked them to identify a champion and a deputy champion in each of the hospitals. And this is the profile of what we eventually got in terms of the kind of a level of health worker that took up champion and deputy champion positions. And you can see it was fairly high level operational managers and professional nurses were two of the biggest groupings. And then there was one medical officer, doctor, and some advanced midwives. So there were 18 of these, 2 per hospital. And we went through a training process. We took each group as a district. So there were 5 hospitals in one group and 4 in another. And I think we took them away for 3 days and had some intensive training where they could work with the activities. They could facilitate them and get feedback from us. They could do role plays, so you could see in that activity someone's pretending to be a mother in pain, and there's a nurse, and we did various role plays and activities. In this activity, my colleague, who's the organizational psychologist, is going through some videos that we had provided and showing them how that could be a learning activity. These are further pictures of the kind of participatory nature of the training that we provided, and we tried to make it fun as well. And then we said, after the training of the champions, they need to go and set up their groups in the hospitals, constitute the learning sessions, and for a year, they should run learning sessions. And so you'll see in these pictures, often the learning session taking place in the maternity ward corridor because they didn't have a separate room, and then the forms that they would fill after sessions, send it back to us so we could see, and then some of their work on newsprint as well, which we asked them to keep a record of as they were going. So this is the activity, which was a transect walk, which we called learning in the footsteps of your patients. And this was really very helpful. And a lot of the change projects that the team selected emanated from this activity, from actually just going to the front gate. So in this activity, one of the nurses has got a pillow, I think, under her garment there, and is walking with their team right from the entrance to the maternity ward, and kind of trying to see what it must be like for a mother, often without directions, no wheelchairs available, and so forth. And they did it so well that I observed one in a hospital where the mothers, when we eventually got to the ward, didn't recognize that it was the nursing staff, because she was really just doing it so well and with all the kind of expressions of pain. And then other health workers also came out because they thought it may have been some industrial action going on that they were not aware of. So it was really interesting. But then it helped them plan, and I'm going to move on to get to the plans. Nick, I think you must just tell me when get to about
31 past.
Okay, good. So, what we also did was provide ongoing support as they were working over the year. We visited hospitals. We had a WhatsApp group going for each of the districts so they could check with each other. And it also allowed for peer learning as well. And we did telephonic support, not too much email support. But we also then ran 2 workshops, midway and at the end, and we provided regular feedbacks on the forms that they submitted. So this was the midway workshop where each of the teams got to present on how their PLA process was going, what challenges they had. This was the only medical doctor that was in the team. That's the midwife from one of the hospitals. And then at the end, in January this year, after just more than a year of being in the process, we called it a celebration workshop where they could come and tell us how it had gone for the year. We offered certificates for the teams that had met most often, that had the most innovative change projects. And we kind of tried to give some incentives and awards for teams to kind of celebrate their success. And we brought in the district officials at this stage as well, because the idea was that the districts also see what happens and hopefully support the project to continue. So I'm going to share now a little bit of what we're finding at this stage, and some of this is really preliminary data. I got one set of data late last night, which I will share, and then I'll wrap up. So we found that on average, they were each of the 9 groups. They held about 9 learning sessions. They had about 15 health workers in attendance. And the support that we provided was on average about 6. This is the participation in sessions, and you can see that the level of health worker that participated the most was enrolled nurses and nursing assistants and professional nurses. And doctors, we were quite pleased with that. I actually didn't expect that, because doctors are often in limited numbers at these rural hospitals and are quite stretched. So for them to be attending learning sessions, that was very pleasing for us. We were disappointed at other levels, like particularly the quality assurance manager. What you'd expect their role as quality improvement would be in attendance more, and we didn't manage to secure that. In terms of the 14 participatory activities, and then we had some training videos as 15, this is the kind of the completion rates that we found. So some of the early ones, when they were planning projects, you can see were done fairly well and consistently. And then, some teams chose, and some teams had difficulties, staff rotation, night shift, a champion leaving a hospital for another hospital, all affected the dynamics in the group. This is some pictures of learning sessions and one of the quality improvement projects that hospital in Freya chose, where they created a poster and put it up so that patients could also be aware of the importance of respectful care and that they were entitled to respectful care. This is another activity on, we called it the silent graffiti, where health workers would reflect on the kind of, what patients say and what it feels like if a patient, said something negative and positive and so forth. Now, the important thing was, obviously, we wanted each of the 9 hospitals to select 3 improvement projects. And you can see from here the kinds of projects that they chose. Sorry. The bird companions project was the most popular, the introduction of bird companions. 7 of the 9 hospitals introduced bird companions. And another project that was, 4 hospitals chose was improving signage. And that came directly from the Transact Walk, from going there and seeing that there was not enough signage. And they then, so bird companions first. So they then went and created better signage. So this is some pictures of hospitals that introduced the bird companion, and they were keeping a tally. More of that on bird companions. And these were some of the change projects around signage, where they painted signs so that a mother could follow and get to the maternity ward as quickly as possible. So this is the results that I just received while I was here, which the team is really excited about, and some of these were not expected. 3 of the 7 dimensions of learning show significant improvement, and also the end-line interviews are showing that health workers were saying things like they really felt included, that they have a sense of agency in being able to change their situation, that they were learning. And interestingly, quite a few of them said STAR had become like a code. So in the ward, if there was an indication of some disrespect, someone would just say STAR, and it would be like a kind of code for them to say you're not following the kind of STAR message in it. And then on the PCMC, the results I got last night, there again, two domains of the person-centered maternity care show significant improvements. And this is the slides that I got on the PCMC. So overall, the full PCMC scale, I think re-rated for 100%, showed a significant change. Dignity and respect was already high at baseline, and dropped a little. And then these 2 have also seen significant change in terms of communication and supportive care that was received. And that's specifically around asking for permission to do a procedure without just going ahead and doing it like it was happening before, calling patients by their name rather than a number on the file, supportive care, introduction of bird companions, and those kinds of things. But also privacy. 1 or 2 hospitals actually put up curtaining between beds and so forth if they didn't have that. So quite hands-on projects. So 2 final slides on my reflections, and then I'll stop. I think for us it's really interesting in terms of doing PLA in a hierarchical organization. So one of the papers that I'm working on at the moment is on this aspect. To what extent was the project participatory and bottom up, and where did we deviate from kind of what is typical PLA? We found that hospital managers' buy-in was slow in some places, and it really slowed it up. So for 3 months, sometimes STAR didn't run it in 1 or 2 places. And then we had to get the intervention of the district to send a message to the hospital manager. And so some in the team are saying, well, maybe that's not PLA because you brought in some powerful figures to move things along. And maybe that's the nature of trying to do PLA in a hierarchical organization. And then we also thought that there was low involvement in some places from doctors and QI managers, given that that's role. I think a big question, obviously, that we can't answer now is, will this continue in the wards, without our support outside of this project? We did involve the district, and at the end, the celebration workshop in January, we brought the provincial managers to say to them, so that they could see what happened, and they were quite excited. So what I've got at the bottom there, some of the unplanned things came about just because we brought in these very senior provincial officials into it. They said, well, this is great. There's a perinatal conference in March. We think some of these STAR champions should present. 4 of them presented. They asked us to collect the SOPS's standard operating procedures for birth companions, because each hospital developed one before they could implement it. They wanted a little kit. We didn't expect that, so we've gathered that and created it. One of the hospitals had a bereavement support group for mothers that had lost a child, because often mothers would be in the ward where there's mothers with babies. And so they wanted to create a separate ward and provide ongoing support. And they liked that. So we now have a PhD students doing a study on that aspect. They asked us to extend STAR to 2 of the clinics that were not included, and we've done that. One of our leaders, one of the STAR champions who presented at the perinatal conference just last month, was also asked to present at the national conference, and she's wearing that white gown, which at the back, I didn't know, says STAR ambassador. So she's also now become like almost a trainer, and she helped train in the other facilities. And we've also just sending someone out in the next couple of weeks to go to 4 of the hospitals to take the manual there and say what worked, what didn't work, what can we change, just in case the province wants to scale it up. We'll have a revised manual based on the pilot. We published the design article in January this year. So I just put that up there if you do want to read a bit more about the kind of intervention, because there's a lot more detail than I was able to share. I have sent it to Nick, I think, so you can get it from Nick or myself. And that's where I'll stop.
Brilliant. Thank you, Vaughn. Can I invite questions?
Was there any financial incentive to be a champion?
No, we made a deliberate decision that wouldn't be the case. And we put that into the manual and into the guidelines when they were selecting champions. And there wouldn't be a financial. The only thing we did do was at the midway, we kind of created some categories of award, who met the most, who had made the most progress with their QI. I use the term QI, that's quality improvement. And we were told, don't come with new language into this hospital. Don't talk about PLA and all of that. So in our early meetings with the province, they said, if you bring in another kind of discourse and it looks like it's something new, you're going to really create some problems. So use what's existing and what staff are familiar with. So we kind of said, look, you made the most progress with the QI project, or this is quite an innovative QI project, and we gave them some awards and we gave them vouchers, and it was often vouchers that they could use to buy, tea things for their next meeting and stuff like that. So that was the only financial incentive. But the certificates helped because there was a lot of, interest in having that on your CV, and also being profiled in the district with their district managers being present. The champions really enjoyed that kind of exposure and kind of signification of some leadership in a way.
Thank you. Hi, sorry. The teams presumably knew the feedback from the questionnaire
you know, your vision, question about respect and things like that. Were they surprised, do you think?
So you know, I actually hadn't seen all the data. We were told as the intervention team. I think you understand this kind of design.
So I'm just seeing if there's any online.
Okay. That we had to be quite separate, but they did share the baseline with us, and we then took some of that and created these vignettes and case studies so that the STAR teams could read them and be aware of them. And then in the training of champions, we presented some of the figures, but removed the hospital's identities so that they wouldn't have their backs up against the wall. So they knew that there was evidence in that district of disrespectful care and of mothers being shouted at, pinched, told to push, and all that kind of thing. Yeah. But they were not given their set of data.
Yeah.
Just wondering, how, or was there any way to sort of ensure fidelity of the intervention between the different hospitals, given that they're all sort of local staff in the hospitals? How could you ensure that they were delivering the STAR program in a similar way?
So, you know, I think PLA doesn't really, in my experience of PLA and the literature, doesn't hold that everything has to be done in a particular way. I think there's a lot of room for it to be led by the group and to be, you know, to be shaped by what they see and how they read their context. So we didn't say you had to do activity 1 to 15 in this order, but we did say 1 to 5 was really important to do it in that order, because 1 to 5 got them to identify a day when they could meet. 1 got them to set up the group activity. 2 got them to work out their schedule so that they had a common day when they could meet. And then 3 and 4 was really critical in them reading their context and identifying 3 projects and ranking those projects as the most important. So we did say that those needed to be done in that order. Other than that, they could do whatever they wanted in the orders that they wanted, and they did change. And some of them came back to some activities as well. And some didn't meet for 3 months. We got quite concerned about some hospitals. And when we went and visited, and we couldn't reach them, and we couldn't get hold of the champions. And then we heard things like, you know, they didn't get kind of the buy-in from the manager. They couldn't get a meeting with the manager, or a champion was suddenly put onto night shift, and then, you know, there was that disruption. Sometimes someone was transferred and things like that. So we didn't expect nor require that there would, you know, be a very kind of a common process across them. We just wanted at the end of the 12 months that they could have at least identified 3 change projects and have started and completed 1 by January this year, and report to us on how that went and felt what it can feel like to change something, because quite often people are disempowered. You think, you know, in one hospital, they had a person who was regularly absent in the team, and it was a very small team, so it was putting stress and a lot of burnout in it. And the person, I think they ended up identifying that there was an alcohol problem, and they then worked on it and not kind of blaming and outing the person. They found counseling. They, in fact, motivated for a counselor, and that hospital got a counsellor through that project and assisted that individual as well. And that for them was very empowering, in a way, to think that they could do that kind of thing. Put up curtains in wards, started birth companions. Culturally, there was a lot of resistance to this idea of birth companions, even though it was a requirement in the department. And I must say, that's another area where we're wondering to what extent it was bottom-up, because the province was pushing birth companions. And when we saw that the progress was slow in some places and they couldn't come up with the project, we said, well, everyone else is doing birth companions. At the Midway workshop, they shared what they were doing. So I think they kind of influenced each other, and that's why 7 out of the 9 went for it. And we were happy because they were also addressing a national requirement around introducing birth companions. Yet in the beginning, they told us, you know, in the Zulu culture, this is a very rural Zululand area, having men around is not acceptable, kind of thing. And it didn't have to be a man in any way. Yeah. Have I answered your question?
Yeah.
Dennis.
I've got a comment and a question. So firstly, so there was a kind of moment of nostalgia looking at all those pictures, because would have been one of the hospitals I would have been born in. So it kind of looked, there was some kind of familiarity there. But thank you. So what the question I have for you is something around the transit walk. And I remember this is 20 years ago when we worked on HIV as a barrier to learning. Because a lot of these methodologies were kind of
That's right.
played on like body mapping and the transit walk. And I don't know if you remember doing that with young folk. And did you find anything significant doing this with young folk, doing these transit walks at schools, and then doing these with more adult folk at a hospital?
Yeah. So I didn't do it with them. We were not there. You know, they were self-sustaining and run groups, the champions run. But on the one occasion, because we provided support, I happened to be in that Dundee hospital when the activity 4A and B were being done, which is the transit walk. So I got to see it. And I would say it was really real. As I said, you know, the person playing the mother did so well that they drew a lot of attention. To answer your question, in the HIV/AIDS study that we did in Richmond all those years ago, because I was from adult education, you were from schooling, you got to work with the learners in schools. Peter Rule and I worked with the SGB and parents. So I didn't do transit walk, but we did do some activities with the parents. I would say, I don't know how different it is. My other experience of transit walk is in the area of, you know, my chair, which is in peace and conflict. We walked through communities after the violence. And it was really helpful because people kind of forget, or sometimes they wanted to forget about why that building was burnt, or why that, you know, hospital is no longer, the clinic's no longer there, and things like that. So I think it will help, but I don't know that I can say, because I don't work with, you know, in schools so much, how different a transit walk could be. I would imagine that it would play a very similar role in being able to, you know, to stimulate kinds of thoughts and identification that you won't get from sitting with someone in an interview. I think it's the kind of visceral presence of being in the context that helps generate new insights and memories. And so forth. I'll say that in the project that we're just developing now, the Legacies of Violence project, in the last 2 months, we visited 3 communities that were very heavily affected by the violence. Trust Feeds was one of them, where you would remember there were 11 people killed in a vigil. It was a funeral that night, and a policeman went with 4 other policemen and surrounded the house and shot at it. We went back there, and I think if we had to do a transit walk now in that community, just being able to see, because they put up a monument on that site, and they were trying to build a museum, but it's in disrepair. You know, people don't kind of treat monuments in the way that I see monuments of, you know, of war and peace in this country and elsewhere. So I think a transit walk kinds of generates that kind of sense for people, you know, of what the meaning of symbols are. They did talk a lot about the tree that's still there at that site, because it was planted by Jacob Zuma, the former president. Yeah. So you kind of hear things like that from being in the space. But then the difference between young people and old people, I'm sorry, I don't have that.
Just and I loved your comment about PLA and then having this directive from kind of the powers that, you know, you will participate. And I really like that comment because it tells us about how we're being reflexive about what PLA really means, and how does it organically kind of generate by being totally participatory. And I like that comment, and I'd like to maybe ask you to maybe consider reading the work of Frere's contemporary at that time, Auguste Boal. And Auguste Boal did one better than Frere. I do think Frere took a lot from Boal rather than the other way around. But Boal did something quite interesting, where within his participatory work, he introduced what he called the joker or the facilitator, who was intentionally directive of what participation and the direction participation will actually take. So interesting contemporaries of how they understood participatory or participatory theatre, for instance.
Interesting. Bonnie and I were just talking about Auguste Boal in Theatre of the Oppressed yesterday. So, but thank you. Yeah, that is something to consider. I think the expectation that things can be naturally participatory and organic is unrealistic.
That's right.
It's totally unrealistic,
That's
even in a
absolutely.
community setting. So I think we do need someone to instigate, animate, and some outside facilitation sometimes as well.
Because I think if you're too, I hesitate to use the word purist, but if you're too much of a purist about it, there's a real risk that you don't get anything.
Absolutely.
And you don't want to waste time of the people that you've got in the room
Exactly.
apart from anything else.
Yeah.
So a little bit, and often I think people don't know what they don't know. So I think it's okay to lightly touch people and then whenever somebody's good to go.
I agree. I think as long as you kind of hold that Freirian concept of teacher, learner, learner, teacher, and that it's a horizontal and a dialogical kind of process, you're not directing it to the extent where your agenda is being fulfilled through other people. I think it's acceptable.
And key part of the processing of that.
Beautiful. Then one last question, or we good? Thank you. Thank you.